Out of interest, whilst we're waiting for more people to join, is this specifically just women in this particular conversation, or do we have some men in it as well?
I did see a man's name here, so I think some of our members that's joining might be male as well.
That's good. Because I mean, there's also a dependence on women's health on men and men's health on women, so it's always good to sort of bring it all together, so to say.
All right, I see it is 2 o'clock, so I think we can start. If you can record, then I am just going to welcome everyone to our Bestmed Tempo Talk. Today we have Dr. Manganyi here with us, and I'm just going to share with you his profile. Sorry, there we go. All right, so yes, my name is Wilmarie Joubert. I am a Tempo Wellness Coordinator for Bestmed. And like I've said, we have Dr. Manganyi here with us to speak about women's health. We will encourage all our participants to please ask us questions using the chat box, and I will relay them to Dr. Manganyi to answer. And if you want to get in contact with him, you can always email tempo@bestmed.co.za, or at the end of the session, we will open the microphones for everyone if you want to ask him a personal question. So our speaker for today, Dr. Manganyi, he is a medical doctor working as a medical officer at Steve Biko Academic Hospital. He is also the team doctor for Morocco Swallows, FC. He is the founder of Medihealth Solutions, which is a company that is focusing on assisting at-risk youth with a quality, stigma-free, and affordable healthcare. He's a businessman, a keynote speaker, and a leader in healthcare. Welcome, Dr. Manganyi. We are really looking forward to hearing what you have to say to us.
Thank you so much, Wilmarie. I appreciate the warm welcome. I hope everybody can hear me. And I really want to urge, I want to urge women to get involved in today's conversation. As she said, my name is Amogelang Manganyi. I'm one of what I'd like to call a social catalyst in the healthcare space. Bridging the gap between everyday medicine and basically all these complex medical terms that you keep hearing, and basically delivering a different brand of medicine, one that's relatable and one that makes it easy for you to account for your own health and go out and be, an advocate for the health of others as well. And so I'm going to have an interactive conversation with you. There's going to be some clips in it. There's going to be a different perspective to women's health. And, I'm going to try and take it from a perspective that's never been looked at before, because everybody knows more or less health. Everybody can tell me about this cancer and breast cancer and this. But when we start talking about certain barriers that women face to accessing healthcare as opposed to men and how it affects their health, then the conversation becomes very different, because then it becomes uncomfortable. And I'm here to have uncomfortable conversations. I'm here to have thought-provoking conversations. And I'm here to have conversations that will linger long after our time together. And so this won't be a by-rote presentation where you'll just be reading slides of a page, but rather an engaging session of the mind, the body, and the soul. And let me take you on a journey. And when we come out of it, I want you to breathe, relax, give me feedback, and let's engage. Let's talk and let's get to know each other on a more personal level. And trust and believe when I say this is that I understand and I completely agree that the future is female. And we have to be intentional about it. And we have to safeguard the healthcare of women in today's society. And so I don't mince my words. The future of the world is female, and she matters. And so I'm a huge advocate for that particular drive. And I urge all men who are in this particular conversation to also take up that mantle, because the skills are skewed, disproportionately so. And so allow me to take you on a journey. Allow me to, to just educate you a bit more. And I think, Val, maybe with your permission, I'd like to get into it, share my screen, and let's get into it.
Please, please, we are excited to hear what you have to say.
Thank you so much.
You can leave your camera on for us.
I can do that, actually. I actually don't mind doing that. Am I back?
Yes, you are. Thank you.
Perfect. So let me hide this. So, as we alluded to before, my name is Dr. Amogelang Manganyi. I hold an undergrad qualification from the University of the Witwatersrand. I have a I have a diploma a postdoctoral diploma in primary emergency care. I'm finalizing my master's degree in sports, exercise, and emergency medicine. And so I come from a wealth of giving engaging and interactive talks across a broad spectrum of different conversation topics. And today is no different. But today I fear that I'm maybe already too late. To quote the first African female president from Liberia, Her Excellency Miss Ellen Johnson Sirleaf, she says that a nation thrives when mothers survive, and we must strive to keep them alive. I find you draw so much about the spectrum of women's health in that one simple topic, right? We know mothers as nurturers. We know mothers as people who provide care. We know mothers as people who are generally the cornerstones of healthcare in society. And so we need to figure out what it is that we can do to empower said females and really get to understand how for centuries African women have been the mainstay of families and communities, often in the face of extreme adversity. Despite the level of their social status and their large share of the burden of disease and death, they continue to be peacemakers, life givers, entrepreneurs, and providers of care for children, the builders of Africans' future. And this comes from the WHO Commission on Women's Health. And for us to be able to captivate really and completely the true essence of women's health, we need to be able to understand where we come from. It's not enough for us to understand the gender bias, but we also have to take a historical context into consideration. May 28th was the International Day of Action for Women's Health, and this year's theme was #Women's Health Matters. And so we need to sort of take into consideration some of the recommendations that were made from that particular day of action on women's health. And so when we go through the presentation, I'm just going to get into the social, psycho, political aspect of women's health to a certain extent, the barriers to access, and how economic marginalization, your inability to engage at an economic level, has a direct impact on your healthcare. Because who's supposed to look after the kids when you're sick and you're not able to go to hospital? Who's supposed to take care of the family unit when you, as the primary keeper of your family, is unable to go out and seek healthcare? And what happens to that vacuum once you're gone? And these are some of the considerations that, although subconsciously we think about, on a day-to-day basis, we're not acknowledging the actual gravity of what it is, the effect that women's health has on global health. Because women's health is nothing without men's health, and men's health is nothing without women's health and children's health. We all live in one particular system. But to start on a lighter matter, and to basically maybe just give a quick understanding of why it is we're focusing on women's health today and not men's health, perhaps let's take a few seconds to play this graphic.
The old adults here, boy. You get wrong. Come on, let's go.
And so I think we all see from that particular video that we know that women generally live longer than men do. On average, women live anything between 7 to 10 years. They outlive their partners by anything between 7 to 10 years in terms of estimated years on this earth. And so if women are the primary and the basic unit of giving life, and they live longer than their partners to outlive us, then why do they get marginalized so much when it comes to access to healthcare, treatment for HIV and AIDS, and supporting of survivors of gender-based violence? All of these still remain a struggle for South African women. Women's access to healthcare services remains severely constrained. For many women in South Africa, outside of the major metros, even accessing a diagnosis can take months and years. And women and men, I want to remind you about the power of accessing a diagnosis. Access to healthcare and the barriers thereof, financial and geopolitical, it's very important for us to understand in giving this engagement. But I want to play you a graphic about real life accounts and how empowering it is to have access to a diagnosis, access to understanding what is wrong with you, and that perhaps is it all just in your head. We're here.
3 years, almost a year.
7 years. Immune hepatitis.
There we go. Let me take
About 3/4 of the way through the appointment.
Oh, sorry.
3 years.
Found. I was diagnosed with autoimmune hepatitis. About 3/4 of the way through the appointment, she looked at me and told me, "We know what you have. We know how to treat you, and you're going to get better." And I looked at my husband and I just started to cry.
I was told the news that would sort of change my life forever. And they said, "Ms. Garcia, you have a mass." I had a 25-pound ovarian tumor. So it was not IBS. And that's when I found out I had cancer.
I was diagnosed with endometriosis that my surgeon had said was one of the worst cases of endometriosis in a young person she had ever seen in her career.
I was diagnosed with microvascular heart disease. I was diagnosed with a 97% blockage and a 94% blockage in left and right coronary arteries.
I was diagnosed with IBS with SIBO.
And he says, "Honey, it's your arteries. It's your small arteries, like I suspected, that are not functioning properly." I feel like finally someone listened. Finally, I was somewhere where they cared, where they listened.
As a woman, you need to listen to your own body.
You need to be your own advocate.
If you need help, don't be afraid to ask for it. It's okay.
Get a second opinion, a third opinion, fourth opinion.
Don't give up.
Don't ever give up. And don't take no for an answer.
I was shocked and surprised at the disparity between how men and women are treated. And I was just so pleased to find out that Cedars-Sinai is trying to bridge the gap in women's health.
I'm delighted that there are teams of brilliant people doing studies, doing research. It's vital. It's just very important. Very important.
South African women and girls are at the periphery of the healthcare system as we know it. They struggle to access healthcare workers, medications, treatments, and mental support. But it doesn't end there. Women also face barriers to thoroughly enjoying their own sexual and reproductive health and rights. More than 9 in 10 women and men have indicated that gender-based violence is a substantial problem in South Africa. Among women, this was most prominent for those aged between 35 to 54 years of age, 95% of whom had reported this as a major issue in South Africa. And this is very important to the collective whom we pitch this talk to today. Think about yourselves who fall within the ambits of that age bracket. Think about the realities that other women are facing within that particular cohort, and understand that your rights being infringed upon can never be normal, and you are not alone. You need to be your own advocate. Patty, Maria, Henny, Melanie, you heard their stories, you heard their truths. It's not just about what happens today. It's not just about what happens in other aspects of the world. You have to think about what's happening with you. Prioritize yourself. Make yourself and your health a priority. And maybe then we can start to advocate for the change in other aspects, because there's no point in trying to fix the world when you can't even fix yourself. The challenges that are associated with gender-based violence remain significant, and intergenerational relationships are drivers of HIV infections amongst women. Think about the different societal ills that we're going through and how they affect the healthcare of young women, and how that translates to becoming a generational curse. Because if we're not able to identify the drivers of different healthcare states, the drivers of disease and illness within, and how it affects women's health, and subsequently the health of a nation, then we're losing it already from the beginning. If this was supposed to be a talk about HIV and AIDS, TB, sex, cancer, this is not what this is about. We're trying to consciously apply our minds to what's happening in today's society, what's affecting young girls and women out there, your daughters, your nieces, sisters. These are people who could genuinely be struggling with these particular society ills, and that translates into driving certain ills and illnesses within society as we know it. And so let's think about some stats here. And perhaps, when looking at it, let's try and understand where women come from. 1 in 5 women had experienced physical violence by a partner. By my calculations, I counted about 80 people in this particular engagement, right? And so at quick maths, what do we say? What's the number? At quick maths, maybe someone can help me with this mathematics. If you are 80 women and you divide that by 5, we're basically saying that about 16 women right now who are in this particular talk right now have experienced physical violence by a partner. This is a reality. This is what's currently happening in this country. And if you're not able to engage it, if you're not able to be sympathetic to it and understand just how important it is and the impacts that physical violence has on your ability to access healthcare, then you're only scraping the surface. This isn't going to be a didactic lecture about STIs and pregnancy and abortions. No, we're getting into the fabric of the challenges that women are facing and why it is that they are biased against in terms of their ability to go out and seek healthcare. Most men and women did not seek sexual and reproductive health or family planning services during the lockdown. Again, how does that impact on someone's life? If you think about it, if you're staying in a household where your partner is not allowing you to go out and access family planning services, what does that mean to the number of children that people are having? What does that mean to the agency that a woman has over her own body? What does it mean to women who have been victims of sexual violence, who are unable to access the system because it's biased against the human or the female condition? And this is why I'm saying is that once you begin to integrate what's happening with society at lockdown level, on a day-to-day level, at a physical violence level, you are able to now comprehend just what contributes to women's healthcare and what the challenges are that perhaps we don't normally associate with women's health. A much higher percentage of women identified a man in their household as a decision maker. And what does that mean? It means that around 39% of women are decision makers in their households. And what do we know about society, South African society? It's largely patriarchal. It's mostly skewed to the male dominant figure, the head of a household. And if that man is not able to, if that man denies you access to appropriate clinic services, healthcare services, or even gaining yourself into a woman-only gym, for example, such facilities that boost your healthcare as a woman, then what are we doing? Who are the interventions supposed to be poised at? Because if we're not able to understand this, then everything I'm going to say outside of this doesn't matter. If you feel a lump and your husband doesn't allow you to go out and seek help and you die from breast cancer after the fact, what good have we done as a society? If we're not speaking about the influences of women's healthcare and how we can overcome that, then everything we're speaking to will never be accepted. It will never reach the target audience. And let's think about little girls. Let's think about Tandi, who's in a remote village, who's going to school, who's suffering from menstrual pain, the fear of staining her clothes. Let's think about her who's afraid of being teased, non-availability of pads, lack of a private place to manage her period at school. These are amongst the most common reasons cited for menstrual-related school absenteeism. Women are losing almost more than, they say, 17 school days based just on her menstrual cycle. Does it make sense? And what are we saying about her sexual health care? What are we saying about her reproductive health care? Is this something that we have to put away in a corner and not address and not engage because society is not ready for that conversation? Gone are the days where we need to be prioritizing emergency sexual and reproductive health care in males by putting male condoms in bathrooms. I've never heard of anything called emergency sex, but I've heard of having a spontaneous period whilst during maths class and you're trying to concentrate. And so which should we prioritize? And which should really be within our bathroom settings, in schools, in healthcare institutions, in police stations? And this is where we need to come in as advocates of women's health and try and change the tide. So what are the solutions? One, there's definitely a need for us to get more information. Information is power. We need to be able to understand the conditions of people who are living in rural areas, understand the conditions of people living in urban areas, and try and find and cater towards those needs by creating targeted interventions. A bit later, I'm going to speak to you about cancer. And I'm very big on cancer. I'm very big on breast and cervical cancer. I do a lot of outreach work on that as well. But if we're not able to get the information about just how bad it is in any given population, it becomes very hard for us to enter that space and advocate for change. So the first thing we need to make sure is that we need to have power in numbers. We need to be able to get the adequate data. And in other words, we can then have a system to support a gendered analysis of changes in the use of health services. Gendered analysis of changes in the use of health services, not gender biased. Understand what I'm saying. We need to have a gender filtration system in terms of the health services that we're engaging and we're instilling, and allow for swifter and more effective action during healthcare emergencies. And let me give you an example. How many women stay in a society where their husband is well-known or well-respected? How do then they go out within that same society to go and report acts of physical violence or of disease? Or she's nervous that she now has an STI that she may have contracted from her partner, but dares not to ask him, and wants to go to the clinic, but at the local clinic, she's afraid that the person who works there will be able to go out and leak that particular information to her partner. This is the reality of modern day South Africa. This is the reality of a patriarchal environment, which is not taking the time to create sustainable solutions to balance out the scales in women's healthcare. We need to be able to advocate around the application of public health and safety measures, right? Having an inclusive approach, including women, men, girls, and boys people with disabilities, people living with HIV and AIDS, refugees and the likes. We need to have an increased availability of safe spaces. The Gauteng government recently introduced this initiative called the Green Doors Initiative. I'm not sure how many people know about it, but what it basically is, it's a safe haven for women and girls who've become victims of gender-based violence, in which we've got services such as psychologists, social workers, and doctors there who can perform the necessary support in order to help you reintegrate. Because a lot of the times, these victims or survivors thereof are treated like outcasts in society, whereas we need to be able to reintegrate them successfully into society, taking into consideration the various health challenges that they have encountered. We also need to talk about increased advocacy work around gender-based violence, right? And I think you've heard my plea and really where I'm coming from with this. The economic marginalization and the exclusion of women remains a threat to livelihood. Women's economic participation is concentrated in vulnerable sectors, including the social and community service and private households, right? And in the Global Gender Gap Report in 2021, South Africa ranked 80 out of 153 countries for labor force participation, an improvement on its ranking and score from 2006. Now, you look at that number and it sounds like it could be quite impressive, but it's sickening that it's taken us 15 years to move up 10 places in labor force participation. What does that mean? It means that for the worst part, decisions are still made by men, for men, and enforced, right, unequally against women. And therefore, how do you expect women's healthcare to be prioritized when the decision makers at the table, when those that are taking part within the labor force are predominantly male? You have to have participation. We have to have a society, and we need to have a society that's wholly inclusive. Our society remains wholly unequal if women and girls must consider their safety first when navigating everyday tasks like going to the shop or walking down the street to buy bread. How naive of us as men to know that every time we go out home, we will come back home without anybody trying to sexually abuse us. How many times do women have to cut their night short and catch an Uber back home before it gets too late out of fear of their own health and their own safety? These are the challenges that exist. These are the influences of healthcare. And these are the real conversations around women's health that people don't want to have because they are uncomfortable. I'm tired of living in comfort. And I implore you to understand the context of this conversation such that you can empower yourself in making decisions at the top level and including women in everyday decisions, because that's how we win. That's how women's health becomes prioritized. Not by you going to a local clinic every day and getting your pap smears and getting your bloods done. That's all good and well, but if you're in an oppressive environment and an environment that doesn't allow you to express yourself for who you really are, then that falls on deaf ears. Let's look at HIV and AIDS. Let's look at particular health focuses, look at disease states and get into it. We've gone into the psychology behind it, the social factors around it. Now let's go into the biological conditions. And I want to show you this holistic approach to women's health, a biological, psychological, and social understanding of healthcare, because that is what health is. And it's not just merely the absence of disease, right? But biological, psychological, and social balance, and making sure that all of those are in balance. And that's when we can say we're talking to a whole topic around healthcare and women's health in particular. Whilst HIV remains a critical health challenge in South Africa, women and young girls continue to be the most affected gender group in the country. Let's look at social media. Let's look at what's happening in this day and age. Let's look at the advent of young women, perhaps being put in a particular light and contracting certain diseases because of intergenerational relationships. And what does it mean? Are we educating our women enough? Are girls going to school? Are we empowering them for them to empower society and for them to know what they stand for? Because when we fail as a society to educate our young girls, then the direct repercussions of our failure are recorded in the statistics for HIV and AIDS, STIs, teenage pregnancy, and that's really where we need to gauge ourselves as a society. It doesn't need a doctor, it doesn't need a teacher. It just needs you to be conscious enough to be able to just sit down and speak to the affected in whichever space that you stay in. South Africa carries the largest share of the global HIV burden, and studies suggest that HIV and AIDS prevalence is higher amongst the female population compared to the male population in the country. Why is that? Think about this. We know that men are less likely to test for HIV and AIDS, but because of the occurrence of women needing to go to clinics to engage with sexual and reproductive facilities, they are more likely to know their HIV status. And it's not because that there are more women infected with HIV and AIDS, and that's why they're the highest in the population. I challenge you to think about it and perhaps understand that I think there's much more men who are in that gap that are just untested, and therefore the data that we have is skewed. And so it's easy to just say at a crossroad or just a snapshot that more women are infected with HIV and AIDS in this country than men, but what's contributing to that? What are the factors thereof? UNAIDS states that girls and women make up more than half of the 37.7 million people living with HIV. While ending AIDS by 2030 requires that we address girls and women's diverse roles by putting them at the center of the response. You understand the way we're changing healthcare. We're no longer preaching, here are condoms, preaching, take your ARVs. We're taking it a step further. Now we are preaching empowerment, we're preaching primordial prevention, because we're tired of increasing the statistics. We're tired of seeing our young girls and our mothers in hospitals succumbing to this deadly virus. We want to give you the power, and we need to put you at the epicenter of our response in order for us to end this HIV and AIDS epidemic by 2030. It's about reducing inequity in access to healthcare through novel ideas and affordable technology so that we can meet the healthcare needs of all men. This is Dr. Priya Soma Pillay. She's the secretary of the South African Society of Obstetricians and Gynecologists, one of the colleagues that I work with in day-to-day medical practice. And moving from HIV and AIDS, I want us to traverse into perhaps what may be seen as a bit of a more sensitive talk around it. I want us to talk about let's talk about cancer. Can we do that for a minute? Let's talk about cancer. And I want to end off with cancer because everybody always considers cancer as an end of life. Everybody considers it as a terminal diagnosis. Everybody thinks of it as, because we can't talk about women's healthcare when we don't talk about the number one biggest killer of women, which is breast cancer. And if we're not able to address that, and we're not able to take into consideration what we've said, mix the biological with the social so that we can affect change, then the whole point of this conversation would have fallen out the window. So, but first you need to understand what is cancer, right? Cancer is a generic term for a large group of diseases that can affect any part of the body. Simply put, cancer is defined as cells that grow uncontrollably, cells that grow without regulation. You can imagine if you have a pimple on your face and one pimple becomes two pimples before you're able to pop one, and then two becomes four, four becomes six, your rate at which you sort of try to break them down is less than the rate at which they are growing. And that's basically what cancer does. You'll try and break it down here, but by the time we attack that one part, it's grown so big and it's changed so much that we're unable to effectively treat the disease. And that's simply put what cancer is. And it's defined by a forced creation of abnormal cells that grow beyond their boundaries, right? And that's how it spreads. And when you hear the term metastasized, the cancer has spread. Everybody in this room has at least been affected or know somebody who has been infected by cancer. And that's on facts. That's something that we have to understand. That's something that everybody is dealing with in society in general. We know this now, and that's what exists, is that everybody has been affected by this deadly illness. And nobody can say they don't know what about cancer or what effects that cancer can cause in families. Cancer is the second leading cause of death globally, responsible for an estimated 9.6 million deaths in 2018. Cancer kills more people every year than AIDS, TB, and malaria combined. Cancer kills more people every year than AIDS, TB, and malaria combined.
Today, cancer causes 1 in every 7 deaths worldwide. But how does cancer start? And what is being done to combat it? Our bodies contain trillions of highly specialized cells, and each carries genes responsible for regulating cell growth and division. But when a genetic change disrupts this process, cells begin to grow and divide uncontrollably, thereby becoming cancer. The genetic changes that cause cancer usually happen in 3 types of genes: proto-oncogenes, which signal a cell to grow and divide; tumor suppressor genes, which signal a cell to stop dividing; and DNA repair genes, which preserve and maintain genetic codes. Changes in these genes lead to abnormal cell growth, resulting in masses of tissues called tumors. Tumors may be benign, meaning that they remain in one area, or malignant, which means that they are capable of spreading. Through a process called metastasis, a malignant tumor cells will eventually break off, travel throughout the body, and begin forming tumors in other regions. When this happens, the cancer has become metastatic and is most dangerous. The cause of cancer is still a mystery. Inherited traits may be behind some of the genetic changes that lead to the formation of cancerous cells, and so might environmental exposures, such as excessive radiation from the sun or chemicals in cigarette smoke.
So let's run it up, right? Cancer is no longer just a genetically defined illness. A lot of people down the lines have always gone to thought, because this person is of a particular orientation, they're Caucasian, they are they aren't of delineations that are similar to us, we're of different genetic pools. A lot of people think that that's what are the predetermining factors of what causes cancer, and that is not the case. I'm going to show you now how what you put in your mouth on a day-to-day basis is the biggest predetermining factor of whether or not you're going to suffer from cancer down the line. Genes are no longer absolutely our fate. Yes, they give us very useful information about an increased risk, but in most cases, it doesn't determine the actual cause of the disease. You are not your family's diagnosis. Just because your mom had it, your grandmother had it, your great-grandmother had it, it doesn't mean you will. Most biology comes from the complex interaction of all proteins and cells working with environmental factors and not simply driven by genetic code. Now, I'll break down this table very quickly for us to understand. We'll go through the different cancers and we'll have some time for a conversation just after I'm done. As you can see here, only 5 to 10% of your ability to develop cancer is genetic. 90 to 95% is environmentally inherited. And of that 90 to 95%, 30 to 35% of that is predominantly diet-based. So the biggest predetermining factor in you getting cancer and what's contributing is what you're putting in your mouth on a day-to-day basis. Now think about what you're eating, ladies. Think about the genetically modified foods we're taking in. Think about your lifestyle. Alcohol intake, tobacco and alcohol. And I want you to look at the converse. You know, when you look at table number B, when it comes to genetics, what's in the takeaway message from that particular table is, how is it that breast cancer only accounts for 1.8% of cancers, whereas it's the biggest killer out of all of them on that genetic spectrum? It shows you that your genes have a very small proportion to play. Only 1.8% of it is genetically predetermined. The other whopping 98%, 98.2% is purely environmental. And so if you're not able to understand that the biggest burden of you contracting cancer is not longer because of, genetic predisposition, but it's more now lifestyle orientated. Are you exercising? Are you sleeping well? What are you eating? And what are the 5 behavioral and dietary risk factors that we can think about? High body mass index, unhealthy diet, lack of physical activity, alcohol use, and tobacco use. So if you go out for a smoke once in a while, not really exercising, you've got a high BMI, and you have an unhealthy diet, those are the 5 most prominent contributing factors to your development of cancer. And when you look at the cancers, what are the problems here? Let's look at it, right? The most common cancer, lung cancer, at 2 million cases, right? And that's the most common cause of cancer deaths. But look at where breast cancer is in this list. It's the 2nd most common cancer in the world, tied with lung cancer. But look, when you look at cancer deaths, let's look down the list. Breast cancer is far lower down on that list. What is it telling us? It's telling us that although it's a common problem, it's a curable problem. And so we need to dissociate breast cancer with death cancer, because that's what a lot of people think about. The minute you feel a lump, you get an anxiety. The minute you feel that there's something that's wrong, you get an anxiety around, this is the end, I have a terminal illness. And that's not the case. Whilst it's being common, it is not a killer. It doesn't kill to an extent. You got more chances of dying from stomach and liver cancer than you do from breast cancer. And that's because we've put into place techniques that are targeted at treating breast cancer. And so let's look at the 5 top cancers in women, right? Breast cancer, cervical cancer, colorectal cancer, uterine cancer, lung cancer. My focus is really on the first 2. The others I'll just skim by, for reading, but really the most common type of cancer in women, and I think everybody knows this, right? And I think October is Breast Cancer Awareness Month, so we're coming up to that very soon. But the most common type of cancer in women is breast cancer. And the most important thing with breast cancer is to be able to do monthly self-breast examinations. I wouldn't be doing women's health a justice without coming past women knowing how to examine their breasts, right? Symptom-free women aged between 40 to 54 should go for a mammogram every year. And women 55 years and older should change it to every 2 years. And so what are we saying, right? We're saying that as long as you're sexually active, as long as your hormone, before when you're premenopausal, when you're still having your monthly periods, we need you to be doing a mammogram every year from the age of 40 to the age of 54. Those women who have not started yet, whether you have symptoms or not, please, I beg of you, once a year, get the mammogram done. Cervical cancer, the 2nd most common cancer after breast cancer, right? Women aged between the ages of 18 to 25 who have ever been sexually active should have pap smears done every 3 years. And yes, that includes your daughters. Are you having those conversations? Or 2 years later after their very first sexual activity and continue until age 70. Expected age, expected age for a woman in South Africa now around 68, 66 years old. It means that you should be doing pap smears until you die. That's pretty much it when you look at the average age. And so if you can outlive it, perfect. But this is basically what we must create, a culture of having difficult conversations, especially at a younger age. The South African government instituted the human papilloma vaccine in grade 6 learners as a broad campaign to assist in the prevention of cervical cancer. Mothers were up in arms. Parents were all in uproars to say, are you basically perpetuating or postulating that our children are sexually active? And no, we're not. We are trying to get them before we believe is the age at which they start to have sexual encounters. And by us vaccinating them against the human papilloma virus, which is the virus that's the chief cause of cervical cancer, we are doing your kids a favor so that down the line, they will thank you for certain decisions you took in the name of their healthcare. And so those are some of the conversations that we look to be having, right? When we just speak about colorectal cancer, as I said, we're just going to peruse past it. We're just talking about here basically living an active and balanced lifestyle. And when we speak about endometrial cancers, and the reason why I put this in here is because of a topic called endometriosis. Now, when you speak about endometriosis and uterine cancer, it's not the same thing. Endometriosis is not a type of cancer. Endometriosis is when you have tissue that should be growing inside your womb that's implanting in other parts of your body, your lung, your liver, pretty much anywhere, your intestines. It can pretty much implant anywhere and then starts to cause bleeding, starts to cause pain, and can predispose you to developing cancer. But endometriosis is not cancer. No, there is no cure for endometriosis as well. And so if you've got chronic pelvic pain and you don't know where it's coming from, and you sort of stick through it, you're popping tablets every month, please go to your gynae, get a diagnosis, think about the conversation we had about accessing a diagnosis and the power it gives you, knowing what is wrong. Right. As we said, lung cancer, I just feel like because the society smokes, and it's important to know that everybody here smokes. We all smoke, whether we're in traffic, inhaling fumes, whether we're out with friends and you're passing a smokers only area, whether we're all exposed to smoke, whether it being the industrialization of the places where we stay. And so we must sort of offset the idea that lung cancer is associated with cigarettes. It's not. Yes, cigarettes definitely accelerate the causation thereof, but it's not just cigarettes that can make you sick. All right. And so you have to think about that as well. People who don't smoke can also develop lung cancer. All right. Now, I want to just delve into, in the last 2-3 minutes, just delve into the breast cancer and cervical cancer conversation. Then we'll wrap it up and I'll be done. I swear, I know I've got a time limit. So as we said here, that we know that breast cancer is the most common cancer in women. And, obviously, we've got 1.7 million new cases diagnosed in 2012, representing about 25% of all cancers in women. Funny enough, we had 3.4 million new cases in 2022. And so you can already see that we're on an upward trajectory, and that's linked to the lifestyles that we're living. Think about lifestyle. Think about access. Think about access to foods, access to security, access to healthcare, and diagnosis. All the things that influence your health as women. Breast cancers are almost all carcinomas of the lining of the ducts in the breast, right? So the channel in the breast that carries the milk to the nipple, that's usually where we're seeing cancer start to sort of begin. So breast cancer risk doubles each decade until menopause, after which the increase slows. However, breast cancer is more common after menopause. Warning signs. Now, this is just a graphic. I can share this. This is just a quick depiction of, if you're standing in your mirror, you've taken a nice shower, you're now getting dressed, you're getting ready to sort of moisturize your skin, and you're looking at yourself. Look at your beautiful body. However way it is beautiful. And look at it and pick up what's not normal. We need you to be the first point of call for your own body, woman. We need you to be your own doctor first, because you are the only person who can tell us what's wrong. Look for puckering of the skin of the breast, a lump in the breast or the armpit, changing the skin around the nipple or discharge, dimpling of the nipple or the nipple going like it's going back, right? An unusual increase or shrinkage in the size of one breast or recent asymmetry of the breast. All women will tell you that their breasts are not the same size. Gentlemen, I hope you know that. It's not abnormal to have breasts that are, but we're talking about an unusual increase in the asymmetry of the breasts, right? One breast hanging lower than the other, enlargement of the glands, and unusual swelling in the armpit. That's it. There's the breast cancer self-examination. I know you guys can read up on it, but as we said, I always like to think about it like you get out the shower, you thank God for giving you life. After that, you stand back and let God take control. Put your hand under on your breast. You start with circular movements out all the way, and then back in, linear, then up and down. And that's basically what it is. Then you do that sitting down, and then you do that lying flat on the bed as well. Quick, simple examination. You can teach your partner to do it. You can do it yourself. It's really not that comprehensive. And this is basically the life cycle of the examination. So you basically examine yourself. You pick up some of the symptoms that we said. You then come to us. We do a mammogram. We do ultrasounds. We take a piece of it, do a biopsy, and then we start with the treatment of breast cancer. I wanted to just joggle on some of the myths and the facts around breast cancer. One myth was, I'm too young to get breast cancer. Many women who are aged under 40 are actually being diagnosed with breast cancer as we speak. It doesn't matter if I'm overweight, obese, and don't exercise. The fact here is that being overweight and having low levels of physical activity adds to your breast cancer risk, especially after menopause. Alcohol and smoking is not linked to breast cancer. In actual fact, alcohol and tobacco use increases the risk of breast cancer. Another myth, only women with a family history of breast cancer are at risk. The truth is that all women are at risk, but family history increases that risk. Think about Angelina Jolie. Think about the power to a diagnosis. Angelina Jolie did her research and found that she had a fatal genetic mutation that almost guarantees her future of contracting breast cancer. And because she had that information, she went and had her boobs, she had a mastectomy done and removed her breast tissue and put implants there in order to manage or mitigate the risk of her developing breast cancer. And so, the other myth would be, I've never had children, so I can't get breast cancer. Women who have never had children or only had them after 30 have an increased risk of breast cancer. Think about these myths. Think about these facts. This is the story, right? She had an 87% risk of developing breast cancer and a 50% risk of ovarian cancer. She lost her mother, her grandmother, and her aunt to cancer. So think about some of the things we've been speaking about. Think about the access to information and data and how you can use that to empower yourself and make conscious healthcare decisions for you, for your kids, and for their kids as well. But only once we have this information can you make these decisions. Otherwise, we'll forever keep losing women. Because if we're always going to be chasing a lump, if we're always going to be chasing abnormal pain, then we're never going to go anywhere as a society, especially with regards to women's health care. And so I hope that I'm showing you what it means and what exactly and how important it is for you to be able to access that diagnosis.
For many people, a breast cancer diagnosis can feel like a battle they're facing alone. But we are in this together because there are mothers, our sisters, our daughters, our friends. NBCF rallies and screening, supporting, and serving communities across the country because every woman matters. Every story is powerful. Every voice makes a difference. Just beat breast cancer. And every dollar helps. Together we rise. Are you in?
Are you in? A statement that encompasses this whole conversation and really ties me down to the end of my conversation. Are you in? Are you in defeating the bias systems that exist in oppressing women's healthcare? Are you in being an advocate of your own healthcare? Are you in changing the lives of not just yourself, but your fellow sister? And are you in becoming an advocate and an agent of change within the spaces in which you live? And that's what we need. We need you to become a healthcare advocate so that you can impact and affect all the different elements and aspects of women's healthcare. Don't chase illness, chase prevention, chase empowerment, chase inclusivity, right? And when we speak about that, you guys know I touched on going for pap smears, the human papillomavirus, cervical cancer, more information. But I really want to end it off by imploring you to think about the spaces in which you work, the spaces in which you function, and the communities in which you serve. Family units, extended family units, church units, sporting clubs, wherever you are, they may not have access to enter this engagement, but you have. And if anything, and the takeaway message that you can take away from this particular talk is simply, are you in changing the lives of women forever? And with that, I thank you.
Well, thank you so much, Doctor. I think this was just an excellent session, and I see all the hands just clapping for you. Thank you so much. I think some of the things that we can really take with us is we have to advocate for ourselves. We know our bodies. We have to get in touch with our bodies, have a relationship with our bodies, and really advocate for ourselves. Unfortunately, everyone, there isn't time for questions after this session. I know there must be many questions. I want to urge you all, please send an email to tempo@bestmed.co.za, and we will send your questions through and answer you as best as we can. Doctor, thank you so much. It really was exceptional.
Thank you.
Thank
so
you,
much.
everyone, for joining.